life of patient and their families facing problems associated with life-threatening illness. When we are telling about the life-threatening illness, it's not only about threatening or limiting the number of days in their life, but something that threaten the quality of life. So we can say we cannot say it's only about the end of life or any other serious illness. Just imagine a person who met with RTA, road traffic accident, and diagnosed as paraplegic. After the acute care and surgical management, definitely we will discharge the patient from the hospital to home. So when we know when someone gets giddiness and it's very difficult to carry by a person who stands nearby for them. Why? Because it's not easy to handle a person with lose with no that much energy. So in same like when a paraplegic or quadriplegic patient shift from hospital, how their family members manage them. So never we may not think about beyond that limit, right? So that patient may need assistance for all of his daily activities, and very difficult to shift from bed to wheelchair, and the patient is very unfamiliar about how they can use the wheelchair. And obviously other diseases, symptoms like maybe recurrent UTI, other infections, neuropathic pain, and even bed sore also will add to the suffering. So even though they are getting reviewed in our hospitals also, there are a lot of problems they are suffering in their day-to-day life. So all this will comes into the threatening point of view. That's also we can add the life-limiting illness also into that. Through the prevention and the relief of suffering, by means of early identification and impeccable assessment and treatment of pain and other problems such as physical, psychosocial, and the spiritual. So we can discuss a scenario here that a 44-year-old female, Mrs. D, has been diagnosed with juvenile diabetic mellitus. During the home visit, she was suffering from pain. This due to the ulcer had both lowering, blurred vision, bleeding, and foul smell from the wounds. She looked very anxious and scared and had no idea about palliative care. She lives with her son, who is 11-year-old. Her husband left her after the diagnosis, and she had lost sensation in her lower limbs. Because maybe the physical relationship of with the husband is not working well, and she was working as a housemaid before she started to losing her vision. Her activities of daily living was very limited due to ulcer and blurred vision. She lives in a small hut made of wooden planks attached around, and we can imagine there is no point of privacy. So whatever the things happening in the house can be easily visible for a person who's standing outside. They don't even have a bathroom and no proper flooring. The patient sleeps on a tarpaulin sheet laid down on normal ground. So this is a scenario which I can presenting in front of you. So we can discuss how we can manage the psychosocial aspects for this particular patient. So what are the important areas to be assessed from the point of view of psychosocial aspects? Just imagine, and if you have any suggestions or your answers, you can put in the chat box. Otherwise, unmute yourself and we can discuss this thing. Assessment of pain and wound management. anxiety, fear. Yeah. Later followed by psychological assessment and treatment. Source of income, financial issues, son's education should be taken care. Yeah. Care of child, counseling of child as well. So when we look into this scenario, so here it is mentioned like she looked very anxious and scared and had no idea about palliative care. So there is a myth existing in the society here. If a palliative care reference given or somebody from palliative care comes as a home care, I think nothing can be done more with this patient. So that is a kind of a stigma or a myth which is existing in the society. So when the team approaches her, she had no idea about why palliative care reached. So maybe she may think that, oh, I'm reaching the end of life, so that they can. So a lot of that much kind of anxiety and scaring thoughts maybe she's going through. That is one thing I want to point out. So anyway, we can come back to the case, and we can view this patient's important areas of assessment and the prior interventions through the concept of total pain. So here we are going to approach this patient with this concept of total pain. You can see one circle is overlapping the other. So the total pain reported by the patient is always compounded by his or her life circumstances. So maybe because of that, the wound is also not taken care well. Then why psychosocial care is important? When a person's life started to suffer with any kind of disease, maybe chronic or a serious threatening, the days ahead may be unbearable, not only for the patient, for the family members also. So, living with a life limiting or life threatening conditions approach that poses very much stresses and challenges to the person. And a serious illness disturbs an individual's thoughts and feelings, relationship with others, social and spiritual support, and it directly affect the financial stability also. Then how we can do the psychosocial assessment? There are some step-by-step process, and an assessment is an exploration process of gathering information about the person, and um, based on that exploration, the goals and interventions we are setting based on what we are assessed. And what is our aim? Our aim is to identify the problem area which result from illness and may influence the well-being of patient and their families. So how we are identifying the particular problem which results after the patient diagnosed with any condition. So assessment is an ongoing process. As the psychological and the social needs of a patient and family often changes over the course of illness, we are also assessing this patient on each and every sitting with us. Maybe we may not get all the informations related to patient at the first time when we are seeing or at the time of patient registered in our hospital, and even we are taking the initial assessment, we may not able to get all the answers. Sometimes the primary caregiver or a friend or relative, somebody will come for the registration and explain the condition of the patient. So we may get all other details through an ongoing assessment process. How we are collecting that? Through purposeful observations and purposeful conversations. As I told, our source of information primary may be the caregiver, sometimes the patient itself as an informant, And the informations which we need also collecting from the friends, relatives, neighbors, and local bodies. So what are the basement assessment we need? Based on that only we are maintaining, or we are inquiring about the collateral sources also. What are the important areas to be assessed from the point of total pain by psychosocial assessment? So these are the some steps which we are following. That first of all, we need a patient overview, then insight, family overview, socio-economic overview, psychological overview, spiritual overview, psychosocial overview. And the psychosocial overview is not always taking for each and every patient, but it is particularly taking based on the need and based on the requirement and based on the condition, which are directly affect to the patient. So interventions and plan. The first one is the patient overview. It involves the basic demographic details, such as patient name, age, sex, and the address and all. Then occupation before and after the illness. Uh, why we are taking after the illness details? Because when the occupation, most of the patient or the family member who is taking care of that patient may lose their job after diagnosed with that disease condition. Then next is the primary caregiver and relation who is taking care of the patient. And the other thing is the insight. So it is very important in palliative care to know about what the exact diagnosis patient knows about him. Sometimes the patient itself saying, I am having liver cirrhosis, but the patient is actually diagnosed with the cancer of liver. So these kind of clarifications, we actually we actually understand what exact the patient condition is, so that we are taking what are their insight about their condition. Maybe we are asking it directly with the patient, or sometimes with the family members also. So we know exactly about the diagnosis, prognosis, and the palliative care, understanding about palliative care. Sometimes they may think, oh, okay, reference to the palliative care, maybe something. Once the pain settles, they may think that, okay, it's our condition may get cured. So, how about the symptom management and the treatment strategies in other hospital? Everything we need to clear about the patient that we are providing as symptom management care. So all these need to be addressed there. And for that information, we also collecting past medical history and the treatment histories, where patient was taken the previous treatment. So all these things will enter this inside of the patient. And next one is a family overview. In that, first one is the genogram, then family dynamics. That means what are the supportive system for the patient, history of illnesses in the family, any previous history of any conditions like. So it is a genogram, and it was introduced by Murray Baum. It is a graphical representation of person's family over at least 3 generations. That means an extended family genogram. And it involves the structure, dynamic, strength, and the resources. And the basic informations like name, their age, education and occupational profile, and emotional relationship are addressed in there. So what we usually using, these are some of the legends which internationally accepted and using. So for marriage, and when a person is separated, and if a person is divorced, there is a double slash. And for all of this, you can search it in Google and find out. There are a lot of legends are there. So we can also represent with the emotional status also in the genogram, like this. What is about the playing, friendship, so the intimacy, whether the relationship is hostile or any violence is there, emotional abuse, for sexual abuse, and neglect. So once we recorded these all informations in a sheet, whoever handling the situation or future, it is very useful for the reference. And this is a symbolic representation for the case which we already discussed. And this female D, our patient who is separated, not legally with the, her husband, and they have a son. So the son and patient is staying together. So that is covered with that circle. So like this, we can represent the genogram. And in the same way, as it is on the relationship status and the dynamics of family, same like we can use a snapshot view of the. This is a snapshot view for a social system. Like a genogram, we can use what are the supportive system for the patient, and we are using an e-commerce for that, and which is a pictorial representation of patient family in its social environment, relationship with the larger society. So easily we can identify whether patient is going to church or patient have any other NGOs who is supporting, is any hospital is nearby, or whether the child is going to any school, or what are the other communities, whether any community support is there, with the, if there is any good relationship with the neighbors, and lot of things we can capture in a particular view. So that is representing in the ICOMA. So it is like this. So social, that emotional, when we using that kind of symbols, no, hostile, emotional symbols, we can represent that symbols here also. If there is any conflicts between the neighbors, we can point out with the dotted lines, and any violence, we can use conflictual type lines. So this is an echo map, and thereafter, we are taking the socio-economic overview. It involves whether the patient having adequate amenities, basic amenities like food, clothing, shelter, breadwinner who control the finance, um, source of income, debts, social support in the sense, governmental schemes, local financial support, any community support, um, education of the children. So whether any patient, whether the child is dropped out from the school due to the illness of the his mother. So all these things can be pointed out in the social economic overview. Next is the psychological overview. There are a lot of possible psychological impact, maybe in the form of emotional shock, uncertainty, and hopelessness. So lot of psychological distress may be present. If it is not handling or we cannot maybe deal clearly, we can refer to the professional like clinical psychologist and any mental health specialist. If it is not can be, if we cannot able to handle it properly, means maybe it's very worsening condition or beyond our limit, we can definitely refer to the specialist. Then anticipating grief. So anticipated grief is not at all, sometimes it's not only related to the disease condition or the end of life, but it's anticipating about the family members' status, maybe the financial concerns, or about the daughter's marriage, or what the families do after my death, and sometimes the suicide ideation, or wanting instant death. So a lot of things will be there relating to the grief, and what are the coping mechanism they are using for. So how they are coping with the illness, whether it is poor, or is they are adjusting with that, or they whether any diminish happened in their social interaction, what is the coping strategy they are adopting. And next one is the spiritual assessment. So spirituality is it's your connectiveness, and it's not always your connection with the God or a religion. It's about your heart. And when we are asking questions, these kinds of questions, this is a modified version, and see what is the connection. That means who are the persons or communities you look to for support. What role do they have in your care? Do you have an image of power greater than yourself? Has your life situation now affected your feelings about yourself, your faith, or your relationship, and the meaning and joy? What has been most important in your life? What are you most thankful for? What made or has made you happy? What do you feel the proudest in your life? Strength and comfort. So it is. Is there anything that is confronting to you now? What helped you get through difficult times in the past? Who or what is your source of strength now? So we can ensure who are the strength, how they are coping. That is also a little concern which we can add there. Next is the hope and concerns. Is there anything that you hope for? Is there anything that feels unfinished? That is a delicate question, and we cannot able to ask the question directly. But in a conversation, we can develop. We can ask from childhood itself how the memory was, how the strength, and lot of things we can ask. So like that, we can develop these questions and ask to our patients. These are very simple questions, but definitely we get answers for all these. And because at this time, no one bother about to ask about these kinds of older memory or favorite thing to patients when they are suffering with illness. So once the pain gets settled and what depends upon their mood, we can ask these questions to them. And next is the psychosocial assessment, to know about their interest and the relationship quality. And basically, we are using this for quadriplegic and their paraplegic patients with their request. And when we feel that they are having some conflicts in the sexual relationship with the um, partner, so based on their request, and also we are need to address these problems. So some of the sample questions is like, and one thing I want to point out that we never, with the proper rapport and with the proper assessment, with over a period of time, the patient is there with you, or you are dealing with that patient only. You should ask these kinds of questions to the patient, and whether the gender, our gender, whether that patient is a male and he is not comfort with a female to asking all these questions, you can definitely refer to your colleague for the same. So these are some sample questions that do you understand the importance of sex in life, or do you find any changes in the desire of sex in your life? Do you get an erection? Do you have ejaculation? So for your understanding only, I kept some of the questions. And do you desire for marriage? And do you want divorce or breaking up the relationship? So the answers may vary, and if it yes, do you want a divorce means if they are telling yes, so maybe the reason we can sort it out with the proper counseling system. And these are the steps of assessments which we actually want to follow, and we can move back to the scenario. So based on these all covering all these aspects and the steps, the areas we focused, again we can move to the scenario. And now I think you are able to give more answers, focusing on each and every area. So I am expecting all of your participation. So you can leave that answers in your chat box or unmute yourself and we can discuss. Did she ask how long I am going to live? Yeah, definitely. She is also having some hope regarding her life, but she's having suicidal ideation and she's having hope in her life. So, and these are the detailed psychosocial assessment. It was found that Miss D is very grieved and she does not have any kind of support, and she need assistance for all her activities of daily living. She was unclear about the prognosis. She was worried about daily living because she couldn't even manage at least the basic needs. She think that she could be to get back her vision after an eye surgery, but there is no one to take care of her and provide financial support for the surgery. Here, relationship with the husband and his family was strained. She was very hesitant to go out and interact with the people with her foul smelling wound. Poor housing condition is also one of the reasons for uncared and progressing ulcer. She lives in a very rural area and the conveyance to hospital was very tough. She was worried about her son's education. He was discontinued his schooling and only look after his mother. His social interaction diminished and lack of proper care leads suicidal ideations. She was in extreme spiritual distress. She could not understand why she had to suffer so much in spite of being a strong believer of God. So, these are the basic interventions which we found, and based on the interventions, and based on that assessment, these are the interventions which we provide for this particular patient. So, each of the condition is very challenging. Even the patient having does not have a basic amenities for food also. So if she's not having food, but even we are providing a food kit or any provision for food or any support, the ration support from the government also, she's not able to cook the food in that house. So that is challenging, and there is no any community involvement, and nobody somebody is there need there for taking care of the child's thing, and there is no relative support. These all things are challenging. So what are our basic interventions is like provide education, health education regarding DM management and health prognosis. So the support of an advocate and register the case at Childline and file petition at District Child Protection Unit. Informed local authority and with the help of the community volunteer arranged 3 times meals at a hotel nearby to her home. So these are the primary interventions. Assistor had to avail a disability certificate, sought the help of social media, and ensured monthly financial assistance for her. Coordinated with Taluk Legal Service Corporation, and they provided a ration card within a week. Applied in Panchayat to get her a shelter facility via um, Legal Service Corporation. Meanwhile, provided a temporary home for her, and the expense was managed by in another NGO and Palim India. Physiatrist consultation was arranged, provided walker, wheelchair as per their advice, provided glucometer and normal chair, coat, mattress, facilitated ophthalmic consultation and eye surgery. Then the healthcare team monitored her DM and regulated it before her surgery, continuing wound recovery and management, applied for governmental ration support and disability pension, assisted her to obtain Chief Minister Relief Fund, and she received the beneficial support. Psychotherapy and supportive care has been provided to son, and her son was introduced to the children group, and he took part in summer camp, provided financial support for education, and provided a mentor for son who can monitor his education progress. Contacted her husband and started family counseling. Later, husband decided to live with the family. Ulcer debridement was done with the help of a podiatrist, provided a refrigerator to store her insulin and diet charter food, provided financial help to travel from hospital to home and other needs, planning to empower Ms. D with a sustainable income. That means the vocational rehabilitation once her ulcer get healed completely. So these are the interventions for this particular patient we dealt with. I just touched all the aspects because for your better understanding how deeply we can engage a patient care. These are some of the general interventions for we can use our patient. Family meeting, supportive counseling, CBT-based communication, facilitating psychoeducational support groups, recommendation for government schemes and other financial assistance, linking with community resources, vocational training, and regular follow-ups. So these are the interventions. If you are not able to understand or doing assessment in a regular your time, you can refer to any NGOs or even if you have any multidisciplinary team managing this or the social workers is with you, you can refer these kinds of special cases which you are identifying. And next is the dignity. Dignity is the inability to acknowledge personhood. The insensitivity of not acknowledging personhood can be psychologically devastating. And this is an evidence-based study conducted by Dr. Harvey. And it is used in a lot of nowadays to take care of patient and family members. So how we should identify each person is need to get some kind of acknowledgement what they are doing, and nobody wanted to seeking help from other person. So everyone need respect, even they are in a condition of a complete bed bound also. So how we can conserve their dignity? Dignity based on your ABCD means your attitude, your behavior, your compassion, and the dialogue which you are focusing or you are showing to others. We can conserve the dignity and respect each individual person, acknowledge them, not only the patient, you should also consider the caregiver, who is the primary caregiver and how they are taking care of that patient, because we can say the caregiver is one of the silent patient inside that family. If it is a woman or imagine the patient itself happened any patient having a CVA, and if he become bedbound, he is a breadwinner, he is a decision maker in that family. But think about suddenly that patient felt, who is the caregiver? That woman, and she need to be empowered. She have to manage the home. She have to take care of her kids. She have to make the decisions in her life. So lot of things will be comes into their head and how they are managing that. So the caregiver, there are only four kind of peoples in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. So respect each individual and acknowledge their complex. So I can show you one of the video. You can share it.
Today, we see around us many bedridden patients who have lost hope for a better life. Abandoned by conventional medicine systems, they live their lives dependent on the care of their near and dear ones. Globally, 80% of this care is provided by women. Often, women caregivers neglect their own health and well-being in the care of others. Families also fall into extreme poverty because of the illness of the main income earner, the male. Dependent women are left without any means to survive. The Pallium India Trust recognized this crucial need for women caregivers to be supported. With the financial help of the Women's Wing of the Federation of Malayali Associations of America, Pallium India Trust is extending a helping hand to one of the most neglected sections in society, women caregivers. Shaila has faced misfortune upon misfortune. While her husband was stricken by cerebral vascular accident, she lost her 22-year-old son in a motorbike accident. Despite these debilitating events, Shaila faces life with unusual courage. Once again, Pallium India reached out and is supporting Shaila to rebuild her life.
Pallium India, അവരെല്ലാവരും ടീമംഗങ്ങൾ എല്ലാവരും എനിക്ക് ഭയങ്കര സപ്പോർട്ടീവാണ്. ശരിക്കും പറഞ്ഞാൽ ഞാൻ ഇന്ന് അങ്ങോട്ട് മുന്നോട്ട് പോണത് തന്നെ എനിക്ക് അവരെ സപ്പോർട്ടുള്ളത് കൊണ്ടാണ്. എല്ലാ രീതിയിലും എല്ലാവരും ഭയങ്കര ഇതാണ്. എല്ലാവരും എൻ്റെ അടുത്ത് പറഞ്ഞിട്ടുണ്ട്, ഏത് സമയത്ത് എന്തൊരു ഇത് വന്നാലും ഒരു കോൾ ചെയ്താൽ മതി, അപ്പം അവരെത്തുമെന്ന് പറഞ്ഞിട്ടുണ്ട്. അത് തന്നെയാണ് എൻ്റെ ജീവിതത്തിലെ പ്രതീക്ഷ.
Vijay Kumar and Vijay Kumari are siblings affected by an autoimmune disease. Now, at 34 and 36 years, their only caregivers are their elderly parents. While Pallium India provides them with home care facilities, which takes care of their medical needs, their elderly mother needed an extra income to support the family. ₹30,000 was given to Jainamma. She continues caring for the children from home. Rashmi has another story to tell. Her husband, Biju, is confined to a wheelchair after a spinal injury. Rashmi set up a small garment business with which she managed to run the household. But the huge costs of the medical treatment for Biju and subsequent deaths forced her to stop the business. Through FOMA, she was given a grant of ₹30,000. With this, Rashmi was able to restart her small garment business. Loneliness and helplessness are one of the biggest challenges of old age. 60-year-old Sarojini Amma and her chronically ill 70-year-old husband are facing this problem. A small tea shop is her means of earning a livelihood. Pallium Pallium India, recognizing the need to help her with more vessels, etc., became the ray of hope in Sarojini Amma's life. We have just seen 4 stories among the many that the Pallium India Trust has affected through timely aid and care. These women devote their lives to others, but is there anyone to think of them? For many women who feel there is no way out, the rebuilding and concern of these lives by Pallium India Trust becomes an inspiration and motivation.
So now I think you all are clear about how the caregiver is dealing and how they are bearing um, emotional stress and how they are managing. So, so we can ask them that how do I need to know about you to help you better? So maybe that question, while seeing it is very simple, but we will get incredible answers with that. And obviously we will get many kind of, even sometimes the patient is asking about an ice cream, and sometimes it is about their conflicts in the family or any unfinished wish. So until that great extent, we will get the answers. So these are the general interventions of a social worker who is dealing. And social worker is acting as an information center, listening, regular follow-up, psychoeducation and facilitation, counseling, rehabilitation, and beyond that, bereavement support also. So always remember to evaluate our interventions, assess how the patient and families is benefited, assessment how to be revised and updated, good augmentation, and wherever possible, use research valid techniques. And there is an art and science in psychosocial care and us just in medicine. So this is all about the psychosocial aspects which we generally dealing here in palliative care. Uh, Thank you. I think we can move to the discussion. So, Sunil sir.
Thank you, Reshma. The session is open for discussion. Anybody can ask your doubts or your comments, your experience.
So we know that, good afternoon, sir. We know that a lot of these caregivers are having a lot of emotional stress. Is there any strategy or approaches to look into their stress also and do the needful for them too? Hello, sir.
Reshma?
Actually, we have to assess the condition first, whether what is the provoking factor of the stress. Then depends on that only. We need to engage them in various field how it is going through. So it depends basically upon we know each condition of the patient is different, and we cannot compare one situation to other. So what are the phases they are going to, that we need to address first, and based on that we have to manage and engage them with the other um, how the exact problem we identify based on that.
Okay, thank you, ma'am. Thank you so much.
Anybody else?
हाँ बस निकलन नहीं लगा मैं तू पढ़ना स्टार्ट कर दे ते मैं ये कह रहा सी अपने को ना वो आएंगे बच्चा आएगा मैं जावांगा फिर जोसेफ अंकल लेके आएंगे बीट्स
Dr. Navish? Navish? Dr. Navish?
Sir, were you about to ask something?
Dr. Navish? I think I'm okay.
Okay.
Please share any challenging case. So, reference psychological support. So, for all this, most of the patient care, we always deal with challenges as the situation may vary. I think I showed one of the best example and how extent we can do the support. So sometimes the patient wanted to hide their disease with family members. That is a kind of challenging situation. So
Actually, each patient and their problems are challenging. And when you assess, there will be many things which are beyond our capacity. So we are going through this every day, and we don't know what to do in many situations. But then the multidisciplinary team, sit together and come up with some solutions. What can be done? But it is not necessary that we will be able to solve all the problems. But we will try to see whether we can do anything for their suffering.
I know of a case where a patient hello
Yes, Dr.
yes,
Naresh.
I know of a case where a patient around a 55-year-old had brain stroke and he was declared brain dead. He was declared brain dead, and what had happened was the neurosurgery department had sent them home without explaining them much. Here in Punjab, they said just take care of them. There's nothing more we can do, and they sent the patient home. So they were my known. So they asked me what should be done. So even I was perplexed. I didn't know what to tell them because the patient was breathing, but he was brain dead. Pupils were more or less reactive. So eventually, what we could think of was we arranged for some private nursing care, and what had happened was the oxygen cylinder demand increased tremendously. Earlier the oxygen demand was one cylinder was continuing for about 6 hours. Slowly, every 2 hours, oxygen cylinder was being required because saturation was falling. And then the nursing caregiver, because he was professional, he said, "There's nothing much we can do. You are just fighting against the will of God. And what we can do is we can slowly stop the oxygen and stop CPR, ambu bag. If the patient is able to breathe on his own, it's well and good. If the patient doesn't breathe on his own, then let's accept this. So they were very heartbroken, and the family was in denial. But slowly, after 2 days, they understood that there's nothing much can be done. And after that, uh, they had stopped Ambubag, and the patient couldn't survive. So in such situations, it really becomes difficult explaining them. So what can be done as a medical social worker in this situation?
Reshma, did you understand?
Understand, sir, but I think based on the medical aspects, first we have to communicate with the family members, right? So we have to break the bad news and about the clear prognosis. Is that way starting, sir? So, sir?
Yeah. I think we discussed a patient story. In this, I think your group only discussed. Dr. Anvi is in this group.
So can you repeat that name, sir?
Dr. Anil Sujak, is he in this batch?
Yes, sir. In this batch only, sir.
Yeah. So actually, he has the hospital. Actually, I think one of his relatives or friend who had massive MI and was brought to hospital with when the patient's pupils were semi-dilated and they were not carotid and things like that. But during the process, he died while they did CPR. Even there were no. I think for a moment he was revived, but then his ECG was flattened. There was no systole. So this is actually this patient. I don't know if hospitals do like this. Allow the patient to take them home with an ambo bag and tell them that you have to continue with this. Uh, but I think whatever being done is correct. But as a social worker, I think social worker need to get involved at first in itself. Whenever the pupils are semi-dilated, that means the patient has brain dead, and then the social worker has to communicate the same to the people, and maybe after the uh, uh, cardiopulmonary resuscitation. Stage they can
So your voice is breaking.
regular communication should be done. That's what the patient and the family wants usually, and the emotional support to the family is also an important aspect of the social workers.
So this option of do not resuscitate should be given by social worker.
Actually, that has to be done by the I think by the doctor, the team of doctors who are looking after this patient. But if there is somebody who has a chronic illness, and if he or she is under your care, then I think whenever a patient comes to us, then we will ask a social worker to see the patient and family also, so that they will also understand she is a part of our team, and that will gradually help our team to build a relationship with the patient and family. So it is not during that moment, we send the social worker. No, it's not like that. Social worker need to be involved first itself. And the decision regarding CPR and things, when comes, it should be communicated by the treating doctor. And maybe a social worker need to be involved to deal with the family. Because there will be many emotional problems for the family, and we need to regularly communicate with the uh, patient family also. So medical decision has to be communicated with medical communication need to be communicated, medical problems need to be communicated with the doctor, like this thing about CPR, etc.
So here it's the importance of multidisciplinary team, that we can set goal for this patient, and we can involve the multidisciplinary team in that, and decide how we are going to break this bad news with the family members. Then the social worker, definitely, who is continuously communicating with the patient, will always give idea about what they're perceiving and what are their perceptions about the condition, and what are their worries and concerns existing with the present scenario. So all need to be discussed as a multidisciplinary team, and we have to set the goals. And obviously the medical things can be communicated with the the physician can be communicated, and the emotional support, and the family bereavement counseling, and it's starting from the end of life itself. We are providing bereavement counseling, so we are providing warning shots in the first itself, and when the patient is approaching the end of life also, we are providing maximum emotional comfort, so that after the death, we will review this family, and continuing our support until these patient family members get back into their regular coping, how they are coping, and back to their regular social interaction with the society and the normal life.
Excuse me. Good afternoon. I have got a question.
Yes, please.
Sir, it's a very commendable job Pallium is doing, but most of the time we have a financial problems with the patients. Patients always have a financial problem, or their caregivers have a financial problem. How do you raise money to meet this? Like you give financial support to a lot of patients and their caregivers. How do you raise money for that?
Yeah, this is an important question, because if you look at each and every patient after the physical problem, I think the most common problem would be the financial problem in our culture. So, Reshma, can you tell something about this?
So actually, we cannot manage all the financial needs of a patient. We have our limitations, but we have different projects which I showed. No, so same like we have different kinds of project. With that, we can. In that, we are setting some kind of criteria to particularly dealing with some vulnerable patients, and we are ensuring the support. And moreover, that we can facilitate or help them to avail the government support maximum. So that is the role a social worker can done very clearly. They can facilitate the, as I told in that scenario. First of all, we need to ensure whether this patient is having proper certificates for that, whether they have a ration support or governmental support. If the patient has disability, whether he is having the disability certificate, and if the patient is suffering with CA, obviously the government, the state government having, or each state they have some pension schemes. So they will avail that kind of pensions with their regular old age pension. So I think you can visit some of the website particularly for your state, the Social Security Mission, Social Justice Department of the state. Then you can go through the different kind of schemes and support programs providing directly from the government, as well as identifying that you can refer the patients for that. And the other thing, if we are finding some patient is desperately need much more lot of money, you can do a crowdfunding, and we can approach many corporates or many other organizations while discuss their case, and that crowdfunding, I think we can put the case with their concern in media, social media also. So these are some of the tech things we are actually doing.
Okay, thank you, Reshma. I think this is one of the difficult problem, which we will find it difficult to solve, and it is a difficult problem everywhere. I have worked in many institutions, but everywhere this was the biggest, one of the biggest problem. So we have specific projects which can help the patient. In addition, we will try to find out a sponsor for that specific patient. And also there are some government schemes which you can look for. I think this will be different for each state. So I think we can move on to patient story. So Rajalakshmi, can you share the patient story? Yeah. So Dr. Uh, Jeena, Dr. Jena.
So hi. So this is one of the patient story that I have. Can you hear me?
Yes, doctor, we can hear you. Can you speak a little more louder so it will be clear?
Hello, is this better?
Yes, yes, it is.
All right. So it's also a difficult case that I have encountered in my practice. So next. So this is a story of a 75-year-old female, and she had metastatic cervical cancer and had a urinary stent because she had difficulty with she had some form of renal uh, blockage, and since that she has been having recurrent complicated urinary tract infection. Next. So generally, I'm in private practice, and generally patients will call the company that I work with, and they will actually give home care visit for palliative care. So they called me up because the patient had vaginal bleeding, and she's actually having a little difficulty of breathing, and it's actually febrile and had poor appetite. Next. So it was referred to me, so I visited her, and on history, she was actually previously well, and despite her age, she's actually very, very independent. And 1 year prior to consult, she actually presented with vaginal bleeding and difficulty urinating. So at that time, she was admitted, stent was inserted, workup was done, and but the family opted to do conservative care and palliative care. And then 1 day prior to consult, that's why they actually called me because she had high fever and poor appetite again. Next. So she is, when I saw her, she's actually awake, coherent. She was bedbound. She was actually febrile, but the rest of the vital signs was normal. Only pertinent with the P at that time was actually pallor. I did not do an internal exam for the vaginal because I was actually scared to trigger more bleeding. Okay, next. Okay. So when I saw her at the time, so we were actually doing some home care planning, and it was quite noticeable with these families that they really need support because they are all actually not handling well the diagnosis, and they do not have the financial things for their support. And for the patient at the time, she really needed some nutrition. She actually needed like how they will actually properly take care of her at home. Next. So for the psychosocial aspects, of course, they're not very poor, but because they have actually spent a lot already with the workups, with the operation, and so actually they are very religious, and they're actually worried about being tagged that they are not giving like uh she's worried about being tagged as sick and weak. So that's actually, and she has poor family support in a sense that the family actually did not agree with all the treatment plan. Okay, next. So these are the medications that I place her in. So tranexamic acid, I continued it for bleeding. Tramadol initially, but later on, through the end of life, we actually did morphine at home, and then levofloxacin. I opted, since it's complicated, I told him culture will be best, but they actually opted not to do that as well. Next. Okay. Okay, next. Okay. So actually for what is very interesting with this family in terms of the psychosocial aspect is that their mother never actually knew the diagnosis. And she was keeping asking like, why am I weak? What is wrong with me? Why can I no longer walk? Why I can no longer do things that I used to do before? And she has about the I forgot the exact number of children she has. It's actually 6 to 7, I think. They actually refuse to tell her about her illness. And I think it has affected her a lot psychologically because she cannot she cannot verbalize things that I am sick, I am handling all this what is wrong with me, uh and what else? And she's actually like, I cannot go to church again. So that's a stigmatization. Have I done something very bad to God that He is actually punishing me? So those are the three things that actually the discussion point with this patient, wherein actually it was a difficult case to manage at that time.
Thank you, Jenna. So, um, so we have a 75-year-old woman with carcinoma of the cervix, and family is not willing to disclose the diagnosis to the patient. And because of the malignancy, she is very tired, and she has physical problems, and she also has spiritual problems. So how do you manage the family problem of not disclosing the diagnosis to the patient?
It really did took time, but I met them first through a family meeting. I really have to call everyone because the person who I'm talking with actually is she's okay, but the others are not okay. So I think I have to meet them first, and we did the family meeting. So it took us an hour or two and I explained to them the importance of telling her what is a diagnosis. But actually, what we agreed upon was only if she agrees that she wanted to know. So eventually, they agreed to disclose it to her. And after disclosing it to her, now she can express her feelings that she might pass away soon, that she's actually feeling sad and scared. And it's I think it was important that when we told her about it after the family meeting where everyone agreed, where everyone is there, is how she was able to cope with the other aspects of the having a terminal disease, is the emotion that actually comes with it. And
Yeah,
she's able to understand things more.
yeah. So she has seven children, isn't it?
Yes.
So that's very difficult to make a decision. So we have to call them, and as you did it rightly, need a family conference. Only then we can make a consensus among the family, and then only we can go forward. So this is how we already had some class one collusion, how to manage collusion. So I think what you did was correct, and you were able to discuss it with the patient, and she could express her feelings and things like that. So that was good.
And she was able to understand why she's losing the independence. I think that's quite challenging also
Hmm.
for
Hmm.
elderly persons when they
Hmm.
start to lose their independence, that we really have
Hmm.
to for this case, I allowed her to do as much as she can in bed.
Hmm.
And that's part of the planning that we did. Like, you don't remove everything from the elderly person, like they are expected to do nothing. So I told them she's physically challenged now, but you have to understand that your mother has to do something that will help her emotionally. So I think that was a part of the things that we also talked about.
Okay. She had spiritual problems, and Dr. Nina is asking about what was her spiritual need, and was it addressed?
So she was feeling like, I do not understand what is happening to me. So what has God gave me all these challenges? But I think when she finally knew that it was this illness, and then having her family support, and then I told them to, actually, it's not my comfort zone discussing spiritual things, but I told them to call a pastor, because she's not Catholic, she's Christian, and to openly discuss it with a religious leader, and I think that helped them a lot.
Okay. Okay. If we are not comfortable, I think we can actually listen to what they want to tell us. And actually, spiritual problems, we will not be able to find out solution for the patient. Uh, Patient by himself or herself will understand what's the meaning of their life, why this was caused. All this, the patient has to understand from their perspective. It is not our job to make them understand that, okay, this is why this is happening. No, we can't do. We can actually listen to them with an empathetic ear. That's what we have to do. If we don't know anything in spiritual distress, what to do?
I agree. I would generally refer them as well.
Yeah.
But I will give them like small things, that God is still good, you should just continually pray, just very simple things like that, but never,
Mm.
I never go very deep with spiritual things.
Mm. Reshma, would you like to talk more regarding uh, spiritual problems, how to assess?
Actually, what she told is exactly you make her maximum independent as much she can do the things. And what are the things, unfinished hopes or any concerns which she is having. You can also ask for that. Not directly. You can ask, do you want to share any experiences related, any happy moments which you are undertaken, and do you feel how much your childhood was interesting to you, and can you share that experiences? So I think this, when we are asking some spiritual things, as we mentioned, that also help to fluctuate their mood also. So when they will realize what their strength and their comfort, who are caring for them, and what are the things which they wanted actually do in future. So just have some look on that, and we may get answer from her. So based on that, we can communicate with the family members, and we can set goals to make her wish real.
Okay. So Dr. Gopal has commented that if the patient wants to know about the disease, she should be informed. Withholding information does more harm than good, even if it's done in her best interest. Yeah, agree, Dr. Gopal. So there is no doubt that we have to communicate the information with the person who is concerned. So many times patients will think of bigger things than the actual problems that they're facing if we don't disclose the diagnosis to the patient. Anything, any other comments? Anybody? Jenna, do you have any more comments or things to ask?
For this case, I think I have nothing to add already.
Okay. Reshma, do you have anything more?
Nothing so. I think we gone through all the things we mentioned.
Okay. So I think we can wind up the session. So thank you, Reshma, for presenting this the psychosocial